I'd like to apologize for the time delay. We had a few more things on the floor that we wanted to address before we recessed. So anyway, we're going to get right into this. We're going to hear a couple of different presentations today. The first, we're going to hear about non-opioid pain medications. I think everybody's aware of the opioid endemic that we have, or epidemic that we have. And I think medications such that we're going to hear about, they're going to be game changers for a lot of folks. So I have Mona McBride, who's the executive director of the Mississippi Pharmacy Association, and I have Dr. Richard Ogletree, who's the pharmacy director at Telegen. And you'll have to speak directly into the microphone, and make sure, turn it on, make sure it's on. Is it on? All right. Go ahead, Ms. Ogletree.
Okay, excuse me. As was stated earlier, everybody really knows that the opioid crisis has been a major issue throughout the country, and in rural areas such as those in Mississippi, it's been even worse. So I'm not going to give you a lot of statistics about that, because you already know that we're trying to decrease opioid-related overdoses and opioid-related deaths. Y'all know that. One of the ways that that can be done is by looking at options, particularly for acute pain, but even for chronic pain, looking at options that are not opioid and making them easier to get instead of more difficult to get. That can have a huge difference in the lives of our patients. One thing that the CDC said a couple of years ago is that some of their studies showed that someone's chance of still using an opioid 1 year after an acute pain incident increases after 5 days on that opioid, increases even more after 30 days on that opioid. So what we're talking about is a chance to get dependent on opioids fairly quickly. Now, they are valuable, opioids are valuable tools in pain management, but they're not the only tool. And we probably should not be pushing them instead of safer options, or options with fewer dependence and misuse/abuse potential. Okay, so some of these options might be agents. For instance, when we start talking about pain, one of the big pain diseases is osteoarthritis. It's a pain disease. I'm not talking about rheumatoid arthritis, which is an autoimmune disease. Osteoarthritis is more of a pain disease, more pain than inflammation. And there are drugs that can help with that. Acetaminophen, which most people know as Tylenol, can help with that. Although it's not good for inflammation, osteoarthritis is not an inflammatory disease for the most part. Non-steroidal anti-inflammatories can be helpful, but we have to realize that they can be dangerous as well. We don't see dependence, but we can see kidney problems. We can see stomach problems. We can even see bleeding problems, and they could actually interfere with somebody's aspirin that they take to prevent a heart attack or a stroke. So we have to be careful with those somewhat as well. But there is at least one option there, or a topical nonsteroidal. Diclofenac is available on a roll-on topical. That's something that could be very useful. There are other agents as well that can be useful, but we want to make sure that we do not push the patient toward opioids with cost and insurance preferences. We want them to look at all the other options and see what might be best for them. One thing that we do have to be careful about a little bit on this bill that that was proposed, that didn't make it out of committee, but we're still looking at it because we're trying to figure out how we're going to safeguard the people of Mississippi. One of the things we have to be careful with on this is making sure that we don't say that non-opioids can't have step therapy or prior authorizations. We don't want non-opioids to have to step through opioids for step therapy, but they probably do need to step through some more well-established and less expensive and more safe non-opioid options. So when you take away any type of step therapy, that could be a little bit troublesome, and it would give some of the manufacturers a chance to greatly elevate their prices because we couldn't have step therapy on them. So it just needs to be worded that the step therapies should not require opioids instead of no step therapies. I didn't want to spend too much time on this. I know it's important, but I didn't want to just get out here and just speak. I wanted to see if you had questions or see if there's some things that could be clarified. I do work with Medicaid a bit and the MCOs with Medicaid. I do know when we're looking at pain medicines with Medicaid and the MCOs within Medicaid, that is the managed care organizations that work with Medicaid. They do pay a lot of attention in making sure that we're not pushing people toward opioids instead of non-opioids. So at that, I will try to entertain any questions you might have concerning this.
Do any committee members have questions? All right, Ms. McBride, are you going to present also? All right, well, we appreciate you guys coming in. Thank you very much.
Thank you.
Next, we're going to have, I think this is going to be a Zoom call, but Kristen and Andrew Gilley, there they are. Can you hear me?
Yes, we can. Can you hear us okay?
We can't hear you yet, though.
Can you hear me now? Can you hear us now, Senator? Just checking the audio, Senator.
There you go. We've got you now.
Okay,
welcome,
great.
welcome, and I think you're going to tell us about your son.
Yes, my son, our son, Joseph. So first, I just wanted to say thank you, and thank you for letting us join virtually. As you can imagine, both as a mom, caregiver, and full-time employee, it's very challenging to make it up there to Jackson. So I just wanted to thank you guys for letting us do this virtually. So my name's Kristen Gilley, and I'll let my husband introduce himself as well.
My name is Andrew, and very nice to meet you guys.
So we have been residents for 8 years in Gulfport, Mississippi. And I am here today as a mother of a child living with Prader-Willi syndrome, which is also referred to as PWS. And PWS is a rare genetic disorder, and it affects about 1 in 30,000 live births. And we estimate that there's probably about 80 children in the state of Mississippi that are living with this rare genetic disorder, and that's it, right? So when we say rare, we mean pretty special. And PWS is a genetic condition, and what it does is it affects the brain, the metabolism. It also helps to, or will interrupt a regulation of hunger, which is referred to as hyperphagia. And this disease also affects low muscle tone and the hypothalamus of the brain, which will normally would regulate hormones. So with this disease, it's called onset hyperphagia, and that is a severe hunger. So it affects the brain. One day it will affect my son's brain to where he will never feel full, even though his body is full with no problem. It's very debilitating. It's a constant, relentless hunger that my son will face one day. Joseph is 4 years old today, but this debilitating disease will affect him somewhere around the age of 8 to 9 years old. And it doesn't stop, and it will shape every moment of our lives. But right now, if I could share on my screen with you really quickly, I just want to share a picture of Joseph, because he is a fun, loving boy. He loves everybody and he's never met a stranger. He really loves music and dancing. And I swear that he could be the best Walmart greeter in the world, just standing in front of the store saying hello to every single person, because that's his favorite thing to do. But with this hunger that will affect Joseph, it is going to be very intense for our family. And families living with PWS, they don't get breaks. Food must be locked up at all times. Routine is critical. And it must be very, very rigid. Supervision is lifelong. And without proper medical treatment, the consequences are severe and life-threatening. Obesity, diabetes, breathing problems, mobility problems, and even shortened life expectancy. And there's no cure for PWS. But there is effective treatment, and treatment that Joseph takes today. He takes human growth hormone, and it's a very specialized medicine that helps to strengthen his muscles and help his metabolism and all of the things that will come through PWS. And consistency really matters. And interruptions in any of this medical treatment can cause a major regression. And alternative funding programs can really put that at risk for families like ours and other families living with rare diseases. AFPs to me are like paying for an umbrella, and you carry it with you every day. And then when it starts pouring, raining, somebody takes it from you and says, your umbrella is not okay for this storm. And then gives you a list of nonprofit agencies that might be able to lend you an umbrella. However, you're still paying for that umbrella that you can't use. And so in effect, you're being left out in the storm with an umbrella you pay for, and you just can't use it when you need it. And under AFPs, insurance plans remove coverage of these expensive medicines, just like Joseph's human growth hormone. And these are really medically necessary treatments that these families need to have. And, you know, oftentimes families will get sent to third-party vendors to seek charity or manufacturer's assistance. But oftentimes that care is delayed or access becomes uncertain. The AFP acronym, in my opinion, is inaccurate. It should really be called DROP, because it should stand for Denial of Required Out-of-Pocket Protections. So for families like mine, this is terrifying. And we're not asking for optional care. We are asking to keep our children safe and healthy. And really, these parents like families are being forced to make absolutely impossible decisions to pay thousands of dollars out of pocket or risk any treatments that could be interrupted because of these gaps, or, you know, that temporary assistance could ultimately disappear. Middle class families often don't get qualified for the nonprofit help that's out there or charity help that's out there. And then we pay, and then those costs often don't even count toward an out-of-pocket expense. Senator Blackwell, I will say that you have already been a very strong champion of rare diseases, especially because of the ABLE Act that you were able to pass through. And that leadership has helped families that allowed us to really live with some dignity. And AFPs threatened to undo that progress by destabilizing access to essential medical care and leaving us out in the rain without an umbrella. For my son, stability of care is not a luxury. It's how we manage his unrelenting hunger and protect his future. I respectfully ask that you help to ensure the insurance coverage means real coverage for Mississippi's rare disease families. I thank you for your leadership, and Senator Blackwell and members of the committee, we're open to take any questions you have.
Krista, my heart goes out to you and your family. You know, I don't know how people like you guys make it sometimes, but you do.
Through God's will and through great leaders like you.
Well, we'll continue to do our best on this end here to try to help families like yours. Does any committee member have a question? Right. Then I thank you folks and give our best to Joseph.
Absolutely. Thank you.
Thank you. Thank you. Next, we're going to have Dave Weinberg with Live Inova come up and talk about implantable seizure device that he presented yesterday to us in committee meeting. Mr. Weinberg, go ahead at your convenience.
Good afternoon, Mr. Chairman and members of the Senate Medicaid Committee. My name is Dave Weinberg, and I am the Director of Field Market Access covering the Southern U.S. at LivaNova. LivaNova is the manufacturer of the vagus nerve stimulator therapy, or VNS, for patients who are suffering from drug-resistant epilepsy, or DRE. Thank you for the opportunity to speak with you today about this surgical access challenge facing Mississippi families suffering from DRE. I am here to strongly advocate on their behalf and the clinicians who care for them by strongly urging you to fully support to have the Division of Medicaid reimburse hospitals for VNS surgical implant procedures at 100% of Medicare rates for both procedure codes. Those codes are CPT 64568 and CPT 61885. This is a rare opportunity where better care and fiscal responsibility align. What would you think if I told you that treating 40 disabled people could potentially save the state $2.8 million? What's the issue? For several years, outpatient hospital reimbursement from Medicaid and Medicare for VNS implant procedure codes have been inadequate, causing multiple hospitals in the state to discontinue offering this potentially life-changing therapy. With less access to care in the state, patients and families travel long distances multiple times to receive this outpatient procedure. Or if they don't have the financial or logistical means, These vulnerable patients don't receive VNS and continue to suffer in silence. What is epilepsy and DRE? Well, the Epilepsy Foundation defines epilepsy as a brain disorder that causes recurring unprovoked seizures. According to the CDC, 1% to 2% of Americans are diagnosed with epilepsy. Double-clicking on the state of Mississippi, it is estimated that just over 29,000 Mississippians are diagnosed with epilepsy. Drug-resistant epilepsy, or DRE, is defined as the failure of at least 2 anti-seizure medications, or ASMs, by the International League Against Epilepsy. DRE patients comprise about 1/3 of all diagnosed epilepsy patients. This smaller subset of patients do not respond to ASMs after many adequate trials and combination of medications. Their seizures can be frequent, violent, or deadly. There are an estimated 9,800 Mississippians suffering from DRE, with an estimated 1,500 of them enrolled in Medicaid. While 1,500 members seem small, the economic impact on a division of Medicaid could be significant. National Medicaid analyses estimate that DRE patients incur roughly $58,500 in annual medical costs per person due to persistent seizures, high hospitalization rates, and frequent emergency visits. Applied to Medicaid's population of 1,500 DRE members, that could drive an estimated $88 million in direct healthcare spending annually. What are some of the impacts of living with DRE? It strips individuals and families of safety, stability, and independence because of the frequent seizure-related injuries, cognitive and memory decline, depression, medication side effects, and profound socioeconomic hardship, especially for underserved families, all made worse by the constant fear and anxiety of not knowing when the next major seizure will strike. Let's go back to the question of how treating 40 disabled individuals could potentially save the state $2.8 million. To understand how, let's talk about what VNS therapy is. The FDA approved VNS therapy in 1997 as an adjunctive therapy to help reduce the frequency of seizures in DRE patients aged 4 and older suffering from partial onset seizures. VNS therapy involves a minimally invasive outpatient procedure where a small device, much like this one right here, is implanted in the chest area underneath the skin and is connected to the left vagus nerve in the neck via an implantable lead wire. Approximately 2 weeks after the surgery, the prescribing neurologist will set the device to deliver mild stimulation through the vagus nerve to areas of the brain that are associated with seizures to help prevent them before they start and help stop them if they do. So treatment is delivered automatically, maximizing adherence for optimal seizure control. In addition, the newest VNS technology can provide an additional dose of stimulation at the sign of a rapid increase of heart rate, which is associated with increased seizures. Patients and families are also equipped with a handheld magnet for on-demand seizure control. For example, if a patient senses they're going to have a seizure, they can take this magnet that looks like an Apple Watch, swipe it across the device, and potentially prevent the seizure from even happening. If a seizure is already in progress, a caregiver can take that same magnet, swipe the magnet over the device to either stop the seizure or reduce the frequency or severity of it. A swipe after the seizure can also support faster recovery for the patient. So what do clinical studies reveal about the efficacy of VNS therapy? In a study of 465 VNS patients published in 2011 by New York University, they showed that 65% achieved a greater than 50% reduction in seizures after 5 years despite living with DRE for nearly 2 decades. In a 10-year study also by NYU of 65 of their patients, they reported a 76% mean seizure reduction. In pediatrics, a 10-year 400 patient study published in 2025 reported a 90% response rate, and 1 in 5 patients became seizure-free. In a recent study of over 800 VNS patients called Clinical Outcomes in Real-World Epilepsy, investigators discovered that there was up to a 95% median seizure reduction in children. After 36 months, over half of the patients experienced a greater than 80% reduction in focal seizures. 75% of patients experienced meaningful quality of life gains. Such strong, repeatable clinical evidence stands in stark contrast to current practice. Mississippi Medicaid averages an estimated 19 implants a year, signaling a critical gap in access to care. VNS therapy provides substantial cost savings to Medicaid. A health economic study from Emory University evaluating 6 different state Medicaid VNS patients and cost showed that the device paid for itself in 1.5 years because of the efficacy of the therapy and reductions in healthcare utilization. A 4-year study by Kaiser showed a 99% reduction in ER visits in their VNS patients. Here's how Medicare and state Medicaid programs currently reimburse for the procedures. Effective 1 January 2026, Medicare's national average reimbursement is now $45,000 for surgical procedure codes CPT 64568, also known as a new implant, and $31,500 for CPT 61885, also known as a reimplant, when the battery is near expiration. Among 7 Medicaid Southern states, their average reimbursement in 2026 will be $44,514 for a new implant and $36,594 for a reimplant. A 5-year budget impact model that accounts for healthcare utilization costs could yield $2.8 million in cost savings for the Division of Medicaid based on only 40 members in the model. What is Mississippi's current hospital reimbursement rates for VNS? $23,221 for a new implant. This is about 52% of the current Medicare rate, and $16,341 for a reimplant. This is also about a 52% of the current Medicare rate. These rates have virtually been the same since 2020. We respectfully ask for your full support to have the Division of Medicaid reimburse hospitals for VNS surgical implant procedures at 100% of the Medicare rates for both procedure codes, making VNS surgery realistically accessible for patients with DRE across the state. Let's return to where we began. Treating just 40 disabled individuals doesn't cost the state $2.8 million. It could save it. Supporting this bill is both compassionate policy and sound fiscal stewardship. Thank you for your time, Mr. Chairman and committee, and for your consideration. I welcome any questions that you may have.
Thank you, sir. I know the committee heard part of this yesterday. Anybody have any questions? All right. Thank you, sir. Appreciate it.
Yes, sir. Appreciate it.
Next, we're going to get into the heart of Medicaid and have Jennifer Whitworth from the department that she's going to give a real light Medicaid 101 presentation. Welcome, Jennifer.
Thank you, Mr. Chairman, committee. If you can roll to the next slide, please. Or is it here? Should I do that? Or are you doing that? And did you have copies to hand out? Y'all have already done it? Okay, thanks. Good. Okay, so we're going to talk a little bit about hospital payments, hospital payment structure, the provider tax, and just do some general education over what goes into all of that at Medicaid. So can you move to on the slide deck, or yes, there you go. So the box on the left side is really all of the different parts of hospital payments. So there's a fee-for-service based payment, managed care payments, MHAP, which is the hospital access program payment, DISH payment, the UPL payment, GME, outpatient APC opt-outs, EHR payments. Those have ended now, but they were historically made. And then obviously provider taxes, IGTs, and the Working Families Tax Cut Act that all have an impact on what happens with hospital payments. So the chart that you see there is from 2011 through 2024. That's the total of hospital payments, net of the tax. So any impact from tax increases or provider funded payment initiatives is out of that. So you will see that's both fee for service, managed care, and all of these other payment structures that we have. In 2015, you see, go back. In 2015, you see a little bit of a spike there. I believe that's a timing difference from when inpatient was moved into managed care coverage in 2015. And then also in 24, you see the large spike there from the additional MHAP and UPL payments that began being paid in fiscal year 24. So one thing to notice, I guess, without those two large spikes, you see something that isn't exactly level, but it isn't terribly, I guess, tempestuous. You see a lot of ups and downs in that with outside of those two changes. A lot of those payment structures are interrelated. So, for example, when we have the MHAP, the large MHAP and UPL increases, you see the DISH payments go down. You also see the taxes go up because those are funded by provider taxes. So it's a lot of these have pieces and parts that are dependent on other pieces and parts. And so anything can change at any time, and it may impact more than one piece of that entire payment structure. So we do have a saying at Medicaid, and it's nothing is ever easy at Medicaid, and if it was, you did it wrong. So just know that as we move through this. Yeah. I wish it were simple, but with all of the rules and different payment structures that are related, it's just not that easy. So the fee-for-service base payment is really the base for all of everything else that happens. Inpatient is paid on an APR-DRG basis. So that's based on the diagnosis and procedure codes that are built on the patient claim. Outpatient is OPPS and an APC basis. That's really the Medicare schedules. So one of the things, like we talked about in the other slide, how those total hospital payments have been fairly level over time. But when you look in the top right-hand corner, and I apologize to anybody looking at the small charts up there, but you can tell that that decrease, that's actually inpatient hospital discharges over time. So there was a 40% reduction from 2015 to 24. So you don't see the payments actually fall that much. That's because of increases over time to other payments, outpatient increases as inpatient discharges have fallen. On the bottom right is just the fee for service reimbursement part of what you saw on that front screen. So you do see in 15, you see the move away from fee for service into managed care. So when those inpatient stays were covered under managed care, you see a huge drop in their 15 and 16. It's just over 400 million total as you get to fiscal year 24. So in fee for service does drop there from 23 to 24 a little bit, but you will see an uptick in managed care utilization. Those are paid on a weekly basis based on claims that are filed by the providers. Managed care is also paid on a weekly basis by the managed care plans based on the claims that are filed. So we have two programs managed in managed care. One is the Mississippi Coordinated Access Network, or Mississippi CAN, and then CHIP. So both of those are covered under our managed care contracts. And beginning in July of this year, it was the first time we had those covered under the same contract with all three managed care contractors. Previously, CHIP was a separate contract and could have different contractors from our Mississippi CAN population. In managed care, one of the larger populations that are excluded from managed care are really long-term care nursing facility members and our waiver or HCBS members. The fluctuations in payments of services, both in fee-for-service and in managed care, come from lots of factors. Could be utilization of services. Like, for example, when you see the fall in 2021 there, a lot of that is from a COVID impact where people did not go and get the regular services they might have seen otherwise. So utilization of services, acuity levels, the covered populations, but so many other factors can impact what happens there with the payment levels. But overall, I guess one thing to note is it has somewhat leveled out since 21. In managed care, there's about 750 million of those payments on the first slide are made through managed care. So it was 400 million from fee-for-service and about 750 in managed care. MHAP is the hospital access program. So that is the largest payment we make to the hospitals. It's currently in 26. Right now it's that 1,510,000,000. We have sent a request to CMS to raise that back to the level from 25. So based on the federal legislation, we believe we can ask for that other $30 million, and we have sent a request, and that is under review at CMS. So MHAP is paid initially when it was created. The upper payment limit, or UPL, you'll see about that payment in a minute too, a little bit more about it. But the upper payment limit is our fee-for-service rate raised to Medicare. So that is the most that CMS lets us pay on the aggregate, is the Medicare rate in fee-for-service. So in 2015, when inpatient rolled in to managed care, to preserve the upper payment limit that was paid to the hospitals at the time, it was that 533 million that you see there in the upper left under MHAP TPP. So TPP was a transitional payment pool payment structure CMS created and then asked states to phase that out over time. So now we pay MHAP under a fee schedule adjustment, which is both inpatient and outpatient payments. So on inpatient, we have a per discharge add-on, and I think it's somewhere around $8,000 right now. For every inpatient discharge, that payment is added on. And then we have a QIP payment. I'm sorry, the outpatient add-on is 77%, I believe. So any services that are paid for under our outpatient has an additional percentage added for each of those. And then we also have a quality structured payment, which is about half of MHAP currently. So MHAP payments in particular are structured and paid on managed care utilization only. So if there is a managed care member seen in a hospital, they can, when they report that encounter back to us, when the managed care plans report that back to us, we create a payment that will get paid back to the provider. And we direct those managed care plans to make those payments. So those hospital-specific payments are actually based on the encounters as they come in. So we have to make an estimated payment for what we expect to pay during the year, and then we reconcile that after the end of the following of the fiscal year to actual encounters, and that's a CMS requirement, where we actually have to match the utilization that happened during the rate year.
Jennifer?
Yes, sir.
I apologize for this, but we're running a little tight on time. We got to go back in at 3:30.
Okay,
So would you
go
mind?
faster.
Yeah, yes, ma'am, or go ahead and skip to the provider tax component and.
Okay. Provider tax. So I will say, as I'm getting there, provider tax supports MHAP, DISH, UPL, and it supports the, there's an additional provider tax of 104 million in the tax in our code section that currently we actually collect somewhere just under 100 million. So yeah, that's the right slide. So MHAP provider tax is that 322 million. It supports just the MHAP payment. The DISH provider tax is currently that 7.3. So over time, DISH has fallen as MHAP payments have taken up and covered the uncompensated care amount. DISH no longer needed to be paid, and that tax has fallen. The hospital UPL tax is 36 million. And then there's the $104 million hospital assessment. So the reason it's not 104 million you see there, it's 94, is because there is a FMAP component. So as the FMAP or the federal percentages goes up, the amount that has to be paid by the hospitals actually goes down. And that amount goes toward general Medicaid funding. So those are the four different factors I get in the hospital provider tax. We can also have an IGT. So if we have support for any other payments by community or governmental hospitals, that can be paid through IGT rather than a tax. Let's see. On the next slide, talks a little bit about the new federal legislation. So I think that section 71115 about the hold harmless threshold, obviously we're not an expansion state, so that 6% down to 3.5% does not impact us as the structure stands today. There are no new provider taxes, so we would not be able to do that. All of our taxes, provider taxes, and we have 3 of those, 2 others outside the hospital taxes. And they are all at or just below the 6% level. Section 71116 actually creates the requirement for us to move to 110% of Medicare. There have been a couple of different interpretations of how you move to 110%, whether it would really take a full 10 years to do that, or is it just moving from the 187% of Medicare that we are today down 10 percentage points each year, which would not take a full 10 years, obviously. So that will impact us, but not until fiscal year 29. Section 71117 on the provider tax loophole transition, we do not believe that impacts our provider taxes. So on the last page, there was a question about, and we've talked about a waiver for the long-term acute care hospitals. It would increase the tax due from other hospitals by about $10 million because we still have to collect the full amount. So if it's waived for those hospitals, obviously we would just spread that out to the others on a pro rata basis. A change in the tax basis for net patient revenue that's been discussed. It would have to be reviewed by CMS. And I would just say that that new legislation creates a lot of uncertainty around provider taxes and how CMS would see a potential change. It's just hard to know how that would shake out if we submitted a change. So some flexibility might need to be granted. And then one other last note, we have an indirect medical education payment that we've requested from CMS, but have not received approval for at this time.
Thank you, ma'am. Does anybody have a question, Senator Simmons?
Thank you, Mr. Chairman. On your last slide regarding the indirect medical education payments for that $52 million and those 7 hospitals, can you list those 7 hospitals for us?
I do not know them, but I could get it to you.
Thank you.
Sure.
Thank you, Mr. Chairman.
Any other questions? Jennifer, thank you. Appreciate that. Sorry to cut you short on your presentation. Next, we're going to have some presentations by some of the hospital groups or people who are actually affected by the bed tax. And I think first up, we've got Dr. Jones with UMC. Dr. Jones, good afternoon.
Thank you, Mr. Chairman, members of the committee. Good afternoon. We were just asked to briefly give some points about our opinion on the provider tax and how that impacts our facility. Obviously, Ms. Wentworth did a great job explaining how those are all laid out. The current model for bed tax is based on non-Medicare days. So Medicare days were initially excluded as a way to help smaller rural hospitals in the tax program. When the tax program was set up, it's my understanding that there was not the ability to get supplemental payments on outpatient services, which has changed. Obviously, I think that tax model is approaching 20 years in existence. Obviously, you heard from Ms. Wentworth that during that time frame, a lot of you saw the great rise initially in inpatient, and then over time that's degraded. Most hospitals and health systems nowadays, most of their revenue is generated on an outpatient basis. Probably 60+% is generated outpatient as compared to inpatient. So inpatient days are going down for most facilities. So taxing hospitals on inpatient days is a little bit uncommon. Our team did a little research and was unable to identify another state that uses that type of model. Certainly the bordering states of Mississippi use a net patient revenue model, and that seems to be the predominant model that's out there for taxing. There's several reasons why states, I think, have moved to that model and why we are supportive of moving to a model like that. First, if you use all bed days, then that means that a patient that's uninsured that is in a bed is in the bed, you're being taxed for the bed, but you're not getting any reimbursement for that hospital stay. That is approximately $400 on average for our organization per day when a patient is there under the tax and we're not being paid for it. That's for us, about 17,000 days overall. The reality that we're faced now is that most health systems are moving to outpatient type services. So continuing to tax just on inpatient services is really not what most health systems' current revenue stream looks like. So it would be more accurate to tax on a net patient revenue model since we can get supplemental payments on both inpatient and outpatient services now. And then, of course, supplemental payments are used to fund services on both the inpatient and the outpatient side. So taxing only one side, but having to use those funds to fund both sides is just not the reality that we're faced with. So it aligns payments and related tax assessments and disperses the tax burden in alignment with the actual revenue, the way that we receive it. So unlike the patient day model, the net patient revenue model provides more flexibility. It seems in meeting the waivers that are necessary to allow policy adjustments to exempt or lower taxes for certain categories also. So there is some flexibility for being able to recognize that there are types of providers that don't get reimbursement through Medicaid, and allowing more flexibility for them to not have to pay taxes when you move to a model like that. You know, I could give you some specific numbers, but I think UMC is the largest overall payer of the tax of all Medicaid taxes. We're, I think, as a system, the largest provider of Medicaid services overall. So it does have a significant impact to us as a system. I'll kind of stop there and see if anybody has questions for me.
Would a change to net patient have a positive impact to UMC?
So we've not developed our own model. We've seen several models that have floated around. I think the most predominant model would have a positive impact to UMC. I think on in aggregate about $30 million positive impact. There have been some other models that tax different outpatient and types of inpatient beds, and each one of those models has an incremental net benefit, but at a lower rate. So, and that's just the reality of most of our services, and revenue comes from the outpatient side.
Any committee members have questions? Thank you, Dr. Jones. Appreciate it. Next up, and I believe this is going to be by Zoom, Richard Roberson with the Hospital Association.
Hey, Mr. Chairman and members of the committee, are y'all able to hear me okay?
Yes, we can.
All right. Thank you. I appreciate y'all accommodating me via Zoom. I'm in Washington having some meetings up here with some colleagues and members of the administration and our delegation, and very positive feedback about some of the things going on in Mississippi. So I think it speaks well to some of the things that we are doing. The hospital bed day tax came into place about 16 years ago. It was a pretty contentious exercise. I was at the Division of Medicaid at the time. Chairman Bryan was involved in this. Probably still has the PTSD from that June session, as I do. It is a non-Medicare bed day tax primarily, and it was done in that way because at that time, that tax was used to pay for the entire state share for DISH, the entire state share for upper payment limits, which was an inpatient UPL program. It was also intended to capture some of the revenue that was needed by the Division of Medicaid to fund just general claims payments to hospitals. And this was before managed care came into the picture to start paying for inpatient hospital services. It was developed in that way and using that methodology to essentially help the rural hospitals pay less of the tax burden, because the way Medicaid paid hospitals and still does is based off of a volume payment process. So the more patients you see, the more payments you receive from Medicaid. And that holds true today with both the MHAP program for supplemental payments and with obviously the regular claim payments from Medicaid and the Medicaid managed care company. So those larger hospitals paid the lion's share of the tax because they received the lion's share of the payments. And those smaller hospitals that did not have the volume did not pay as much in a tax. And so those still hold true today. And when we've met with consultants as recently as a few months ago and had them look at the model, these folks that work all over the country said, honestly, it still is serving that same purpose and is not a flawed model in and of itself. It could be changed, it could be updated, and beauty of the tax model is frankly in the eye of the beholder. And it is a zero-sum game. When you pay the tax, it is generated in the aggregate, and so every one slice of the pie can change depending on, fluctuations in the tax model. But overall, I think it still serves the same purpose it was intended to when this thing was put into place several years ago. So, one of the things that we've talked about over the last few years from the association standpoint and in my previous role, before coming into this role as CEO, we talked at length with the membership about potential changes in the tax model based off of if and when we could stabilize the distribution model. And the distribution model being those supplemental payment programs, which we now call MHAP. And what we continue to see are changes in that model. As recently as last week, Medicaid talked about changes that are forthcoming in the model that will have an impact on the payments made to individual hospitals. And again, that's a zero-sum game too. So as those payments go up or down, and taxes go up or down, we can see these shifts within the model. So what we talked about for years from the association standpoint of, in looking at all of these payments across the entire hospital landscape has really been to provide some stability and predictability in what hospitals pay in and what they get paid out. And we continue to see dynamic changes across the MHAP model. And the most substantial being just a few years ago when the Division of Medicaid and the governor's office asked CMS to approve a large increase in our supplemental payment program. And when that happened, it was really good for hospitals overall. But what it also did was it increased the tax burden on the long-term acute care hospitals. And Miriam from Select Specialty can elaborate specifically on the impact for Select Specialty. But there are provisions in state law that limit the Division of Medicaid from increasing the hospital tax in the aggregate by more than $15 million a year, or roughly about $3.5 million a quarter. And so those provisions were put in place to make sure that there were safeguards and protections and some predictability into what hospitals would have to pay in taxes. But when that tax model or when that supplemental payment model blew up, the tax model to pay for it blew up as well. It increased substantially, and it blew past that statutory cap, which ended up, it's a $15 million cap in the aggregate. And I think Select's taxes went up just on their end of it by about $4 million from one year to the next. So it created some extreme hardships for our long-term acute care hospitals that were not intended consequences of the tax model and that could have been mitigated in a different way. So, that's really what we've talked about over the last several months, with the chairman, and trying to figure out how can we stabilize the LTACs? How can we make sure that they are still able to do the things that they do? Medicaid does not pay for their services. That is a choice that the state has made in not reimbursing LTACs for adult care. They will reimburse for pediatric care, but they won't reimburse for services provided to the adult population. Absent some very specific, unique circumstances, there really aren't a whole lot of payments going to the LTACs. So they are inherently upside down in our tax model and our payment model just because they're getting taxed, but they aren't able to get paid. We think there's some ways that we can mitigate that for the LTACs so that they can get paid. Or so that they can avoid having to pay the tax. And then also there are ways that we could pick up some additional opportunities to pay them. One of the things that has been mentioned too is that, there's no longer any dish payments to speak of. And that's a product of the MHAP payments going up. So, the tax does capture an uninsured patient in a bed. You would get taxed on that patient. In the way the world was supposed to work with DISH, you did get paid for that patient. You got paid in a DISH payment. Well, now DISH has kind of gotten rolled up and absorbed by MHAP. So you're still getting a payment in a way, but it's a product of what's blown up with the payments. And so we've got some hospitals that are getting money for things that you know that are just coming a different way. And instead of the traditional way with DISH, because MHAP has eclipsed DISH. And it's kind of some technical jargon that I won't bog y'all down with, but that's essentially what's going on there. And then the other payment that you saw on the screen was an IGT program for physician payments that we've asked Medicaid to open up to all hospitals for several years. And right now, that program has only been made available to UMMC. And so, they're getting an additional payment that IGT, they send their own special payment for the state share portion to Medicaid. Medicaid matches that, draws down federal funds for it. But we'd like for all hospitals to be able to benefit from that program. And so we're hopeful that at some point we can kind of realign the supplemental payment world so that there can be allowances and a level playing field there for all the hospitals to benefit from. With that, I'm glad to answer any questions, but I think in the interest of time, I'd really like to turn it over to Miriam Deemer with Select Specialty, who I think is there to talk to you specifically about what really is the most urgent issue that we're facing, and that is how can we solve for the LTACs, how can we solve for our long-term acute care hospitals, and how can we make sure that they remain viable in Mississippi. So I think Miriam may be in the room, Mr. Chairman, and I'd like for her to give you some comments as well.
All right. Thank you, Richard. I'm going to go have another group speak first, and then we'll follow up with specialty. But Kent, are you speaking? Drew? All right. Next up, we've got Drew Snyder, who's going to be speaking.
Hey, good afternoon, Senator Blackwell and committee members. My name is Lori Teal. I currently am the CEO in Clarksdale, Mississippi at Northwest Mississippi Regional Medical Center, and also a member of the Mississippi Healthcare Collaborative. Today, Drew and I are just really going to go over some considerations in regards to the provider tax based upon the collaboration amongst our members. We're here mainly just to not really endorse a particular provider tax methodology, but simply give choices. Dr. Alan Jones spoke previously regarding the initiatives of net patient revenue. Our analysis that Drew's going to present to y'all today will be more focused in that fashion to help get a better understanding of that opportunity. As I now turn it over to Drew.
Thank you. It's good to be back. I wanted to go initially over, give you a little bit of an overview of where provider taxes have come from. And the Social Security Act was intended to allow for states to fund their program through general fund revenue, through local revenue sources, and through healthcare related taxes. About 68% of of the non-federal share of Medicaid is funded through general fund revenue. That other 32 is coming from provider taxes. Mississippi's not much different. Provider taxes have been a big thing across the country. Everybody but Alaska is using them. There are around 17 permissible classes: inpatient services, outpatient services. Ambulance is one that we use. Nursing facility, intermediate care facilities. Those are some of the largest ones. provider taxes come with a lot of federal requirements. And so I think that is very important when we start talking about roadblocks and why things can't be a certain way. It tends to come back to rules at the federal level. For these taxes to qualify for federal matching funds, they've got to be uniform, which means they've got to be consistent across a class. They've got to be broad-based, which means, everybody in a class that's providing those, services needs to be taxed. There is a very narrow exception where state Medicaid agencies can request a waiver. And they look at they look at this statistical formula, and it has to pass that statistical test to get that waiver. And what they're really looking for is, what they're trying to prevent is states taxing Medicaid lines of business at a greater percentage than non-Medicaid lines of business. And so that's where some of the challenges arise when you have hospital providers that are not providing a lot of Medicaid services. The natural inclination, is to tax not tax those facilities and provide some type of relief. But to get that federal matching fund, to get those federal matching funds, it's got to pass that test. The other piece is you can't hold providers harmless. And what that means is you can't guarantee that if providers are paying these taxes, that they are going to get all of their tax revenue back. It is generally the hospital taxes are generally a benefit for hospital providers, but not to everybody, and there can't be a guarantee. And they provide some, the other requirement there is that they call it a hold harmless threshold, or it's the safe harbor threshold is the best way to put it. And what that says is you can tax providers, but you are limited in an individual class to 6% of the patient revenue of that class. So there's really this cap on how much you can use provider taxes before those federal matching funds disappear. Mississippi has traditionally, been well below that 6%, but after the 2023 changes where the MHAP payments went up 900 million total, about 700 million net, we're now closer to that 6% threshold. All right, what are fundamentals of good provider tax policy? If you started over today with a provider tax, if you could, what would that look like? The first thing is it needs to be federally compliant. So it needs to meet all of those pieces that I previously discussed. The other part is it cannot be, since the One Big Beautiful Bill went into effect, it places a moratorium on new provider taxes and on increasing the effective rate of a provider tax. So CMS is going to go in, they're going to look at the state data. They're going to assign a percentage of they call it an indirect hold harmless threshold. And it may be 5.9%. And, going forward, Mississippi can't cross that threshold. And that is important because while Mississippi was non-expansion states have to step down, Mississippi still has to freeze. So, what you're not going to see is a lot of new taxes coming in and relying on that for the non-federal share. The other part is there's a fairness aspect to this. So the idea, there needs to be a tangential relationship. The folks that the hospitals that are paying this tax, and the benefits that are coming from it here, inpatient and outpatient services. Ideally, you would see the tax methodology based on the types of services where where add-on payments or state-directed payments are going. So, and then the last part of a good tax policy is not to use these taxes as a backdoor to fund the Medicaid program. It should for general expenses, and certainly not to for other to plug budgetary holes. Next one. So I think Dr. Jones did a really good job, Jennifer, going over these. It's about $500 million total. 400 go to fund the DISH, MHAP, fee for service, UPL, and the others is for that general Medicaid amount, which has stayed consistent over the past 15 years. The tax, as they've said, is right now assessed on non-Medicare inpatient bed days, and at that time. Inpatient hospital was really the only thing that was eligible for increased payments. Let's go to that next one. What you saw in the mid 2010s is that outpatient hospital services started qualifying for add-on and supplemental payments, but the tax model was not adjusted. Then fast forward to late 2023, fiscal year 2024, MHAP accelerates, going from about 600 million to 1.5 billion. Yeah, a real boost for the hospital industry, but not for everybody. So if you're an IRF, an inpatient rehabilitation facility like Methodist Rehab and others, you're providing a lot of inpatient business, but you're not seeing the benefit that you're getting on the managed care side from these add-on payments is not reflective. It's same with our long-term, the LTACs, they're also, looking at that. It becomes 97% of the hospitals would say, this is a really good deal. But there are facilities out there where this placed a higher tax burden. So what do you do there? Becomes a big question. Net patient revenue certainly alleviates some of those things. And then, when thinking about, what do you do with can you treat them differently? Yeah, the answer is maybe, but it's got to pass that statistical test at the federal level. Yeah, and I think there's been good discussion on what net patient revenue is. It is the common methodology in most states. Tennessee's been using it for a long time. Florida, Colorado is moving to it. It is the dominant method because it looks at all hospital revenue. It ties the tax burden more closely to a hospital's overall financial activity. And it really doesn't punish a hospital for having a really heavy inpatient mix. And I think, as Dr. Jones said, you're not getting punished for providing uncompensated care in the inpatient setting. Really, the challenge around it, though, is it will impact the majority of hospitals would see a negative impact. Governor Barber used to say, good policy makes good politics. I'm not sure that applies here because you're looking at some extreme shifts in winners and losers. And I think, the Baptist system, North Mississippi, Memorial, Singing River, those are examples of large systems that would see King's Daughters, large systems that would see significant losses. Delta Health is another. So I think, but then on the flip side, you also see, you would see hospitals that would benefit, UMMC, Forest Health, St. Dominic's being some. I mean, and also though, I think in thinking about winners and losers, there have been winners over a long period of time that have benefited from this model and some that haven't. A big question that's coming is more and more inpatient care is going to be segregated in certain facilities. I mean, as UMMC continues to take a larger percentage of the overall inpatient work, that burden is going to move more and more in that direction. So, like, we recognize what's net patient revenue makes a lot of sense. Yet you also have to navigate some of the departure from the status quo is disruptive. And what's the best way to handle that disruption? So we have been the collaborative has been working on, some step down models, what hybrid, kind of a blended between inpatient, the non-Medicare inpatient bed days and the net patient revenue. It works because the swings are not as great. Yeah, but you would also see more hospitals losing a little bit of money. There's serious questions too about, would a step down or a hybrid qualify under that statistical test and receive that waiver, that broad-based and uniform waiver from the federal government? Next one. So I think, and I think some of the efforts at the federal level to make sure that the non-expansion states were able to grandfather their provider tax rate will help in the long term with some of these adjustments that we've seen at the federal level. There are some conversations around what can you do with can you move public hospitals to submit intergovernmental transfers rather than paying the taxes, and would that free up some room? I think more conversations need to be, that needs to see really what impacts that would have on individual facilities as well as what federal ramifications, and would that receive federal scrutiny. CMS is going to be providing guidance here on what it's going to look like moving forward with the provider tax rate. I think Jennifer made the point of, there are a lot of ways that CMS can, interpret this, and for the time being, it may some caution may be warranted. As we look at what ultimate path the state is going to have to follow.
Drew, I'm going to have to call right now. We're kind of getting text to be back upstairs, and I want to hear from Miriam on specialty hospitals. But appreciate your presentation. Miriam, if you could give us sort of your elevator speech. Three to five, as we've got to be upstairs.
Okay. So good afternoon, Mr. Chairman, Madam Vice Chair, and members of the committee. Thank you for giving me the opportunity to come today and speak on behalf of a small group of specialty hospitals in Mississippi called LTACs. We're going to go through my presentation very quickly. In fact, we're going to skip the first slide, and let's go, if you'll go to slide 2. We're going to skip that. You can read that and ask me questions later. We're going to stop on slide 3 for just a moment. And this is just pointing out that in the entire state of Mississippi, there are only 7 LTAC hospitals. Select Medical owns and operates 4 of those in the state. And I am the president of specialty hospitals for Select Medical. With me today, I do have 4 of our Mississippi Select CEOs present, but for the sake of time, I'm not going to be able to introduce them. When you look at this, what I'd like you to see is the areas of the state that are already underserved, because you can see the location of each of the hospitals and a 50-mile radius that they currently reach. Also want to point out that these LTACs do not receive direct Medicaid payments. If you go to slide 4, as you've heard previous speakers today talk about, there has been a dramatic increase in the taxes and the tax burden on the LTAC over the last 5 fiscal years. So if you take a look and go all the way to the bottom of the chart to the letters in red, you can see from 2021, 2022, and 2023, on average, these 4 LTACs paid about $2.2 to $2.5 million in taxes each year. But in 2024, due to some of the changes that have been described in the MHAP tax assessment, the taxes more than doubled from 2.5 million to 6.8 million in 2024, and then tripled from the 2023 numbers to 8 million in 2025. I think someone mentioned it earlier, it might have been Mr. Roberson, that the directed payment program that was put in place to keep hospitals open in Mississippi, a good program, but it unintentionally threatened viability of LTAC hospitals. I'd like you to turn to slide 5. On slide 5 here, this is really just showing the difference that we pay in the bed taxes in other states. It's very significant how high the Mississippi bed taxes are for LTAC hospitals. These are all the hospitals that tax LTACs where we operate. These are all the states. But if you go to the very bottom, you can see in 2024, our select LTACs in Mississippi paid $8 million. The next highest is Florida at $5 million. If you go to the next column, you'll see that Mississippi select paid $8 million for 4 hospitals, while we paid $5 million for 12 hospitals. You can see to the far right, the average tax per facility, which is quite high, and the average tax per bed. I'd also like to point out that while in most of these states, but I can use Florida as a recent example, although we're paying $5 million in taxes, we are actually receiving $6 million back in the program. So we are receiving more than we're contributing. So Mississippi currently is a real outlier for our national business. Next slide. So this is really the crux of why I'm here today. The financial picture of these hospitals is really poor right now. If you look on the chart to the far right bottom column, these hospitals lost $6.5 million in 2025. If our company was not so big, they would still not be in operation. We have 104 LTACs nationally, and we operate in about 29 different states. So we've been able to sort of try to weather the storm and keep these hospitals afloat, but these hospitals currently cannot pay their bills and are in a debt position of $6.5 million. If you go to the middle column, again to the bottom row, without the bed tax, these hospitals would have a modest income total of $1.6 million. So my point, and really why I'm here today, is just to share that these hospitals are no longer financially viable, and they are at risk for closure in the near future. And as each month passes, these losses just continue to increase. And right now, we don't see any relief in sight. About a year ago, we were optimistic that we would see relief before the debt reached an unsustainable level. But right now, we're at a critical point. Immediate action is needed to keep this level of care accessible to the citizens of Mississippi. This can't continue indefinitely, and Select Medical will be faced with closing these LTAC hospitals due to their current loss position. We're asking for your consideration and your support to find a way to preserve these hospitals so that Mississippians have access to this level of care. We understand, as we heard from the prior 2 speakers, that this is a very complex issue. We do think there are solutions available for the LTACs. The method or how we get to the solution or get the relief is not as important as, to us, the importance is how quickly we could get some relief. So we're asking for your consideration and support. Some possible remedies that we know have been mentioned previously are, number 1, legislatively exempting LTACs from the bed tax, or perhaps 2, special appropriations to provide financial relief. I don't know how many minutes that was, but I tried, Mr. Chairman.
You did good. And thank you for your presentation. Senator Simmons for a question.
Thank you so much, Mr. Chairman. In light of these presentations today and all the information that we receive, I move, Mr. Chairman, that we expand Medicaid.
You were recognized for a question, not a motion.
That wasn't a question for me, correct?
For the committee members as well as for those in the audience, we have had discussions with the collaborative, the Hospital Association, Select, and UMC, and the consensus is everybody wants to do something to help. The hospitals realize there's going to be an additional financial burden on them, but without the L tax, there's going to be a larger financial burden on them. So we are going to try to work through the process as expeditiously as possible to get you guys some sort of relief, because we do need you here in the state. So with that, we're also needed upstairs, and so we're going to rise and report. And thank you, folks.
Thank you.